Ingrid Hopper, that I think she's no more stranger to us because she has been giving us a talk this morning. And also to move forward, I think she will be rounding up these very challenging sessions, in particular the challenges in the design of future clinical trials in the HFpEF. So Dr. Hopper, please.
So thank you very much. I just wanted to say thank you to all the other speakers who have given very interesting talks. I've really enjoyed them. But now we're looking at the treatment of HFpEF and the challenges in the design of future trials. So no talk on HFpEF would be complete without this graph, which shows that survival rates have improved for HFrEF but not HFpEF. And there have been a number of landmark heart failure RCTs in HFrEF and not quite so many in HFpEF. And as we know, mortality and morbidity have not been reduced with these trials. So the challenges in the design of HFpEF trials are listed there, and I'll go through each one of them. So firstly, defining the pathophysiology, as we've heard about today, is complex. We have ventricular dysfunction, atrial dysfunction, autonomic dysfunction, vascular dysfunction, elevated blood pressure, and valvular disease. But we also have the comorbidities listed there, all of which go to contribute to heart failure with preserved ejection fraction. And as we know, HFpEF is extremely comorbid. The patients are older, more hypertensive, higher rates of atrial fibrillation, COPD, and anemia. And as we've also heard, the actual presentation of HFpEF is very heterogeneous, and there's becoming clearer now that there's clinical phenotypes, which I'm sure will be increasingly delineated over the next few years. So one size does not fit all in HFpEF, and as we've seen, one size does not fit all in HFpEF trials. So determining the diagnosis is also a challenge in the design of HFpEF clinical trials. We know that the clinical features are quite similar in systolic and in diastolic, or HFpEF and HFrEF. And we have these schemas to look at diagnosis, which CMU talked about before, but these have not been applied to major clinical trials. And the enrolment in previous clinical trials have been based on a clinical diagnosis, a prior history of hospitalisation for what someone thought was heart failure, and echocardiograms that exclude serious valve disease or heart failure with reduced ejection fraction performed sometime in the previous 6 to 12 months. And it's likely that many patients enrolled in trials did not have heart failure with preserved ejection, or did not have heart failure at all, and excluding patients with comorbidity may exclude those at higher risk. There's also a lack of consensus definition of HFpEF between trials, and the EF criteria in studies have been variably classified as greater than 40, 45, 50 and greater than 55%. And as an example of this, Charm Preserved had greater than 40%, I Preserved had greater than 45% EF, and these may have a clinical profile that's similar to heart failure with reduced ejection fraction. There's also a subset of HFpEF patients who previously had HFrEF, and they may be clinically distinct from those with persistently preserved or reduced ejection fraction. And in fact, Charm Preserved allowed this group of patients to enter. So we also need easily reproducible objective measures of HFpEF, which we've talked about today. So invasive confirmation of the presence of left ventricular diastolic dysfunction is not feasible in daily practice. Echo Doppler E and E prime ratio has been important, but this has not been associated with cardiovascular risk results in the inclusion of patients who have little to gain in terms of improved cardiac outcomes. And other cardiac measurements closely associated with natriuretic peptides and adverse outcomes are needed to characterise patients and their response to treatment. So one of the other challenges in the design of HFpEF clinical trials is understanding the pharmacology in order to better target patients. So looking at some of the agents we use in HFpEF, so we have RAS blockers, with the target being LV hypertrophy. Some surrogate biomarkers are plasma angiotensin II and serum aldosterone, and with regards to the utility, these are not clinically useful because they're not routinely measured. So similar, spironolactone has the target of fibrosis, same surrogate biomarkers and the same issues. Ivabradine has the sinus node as the target, and the biomarker is heart rate. And heart rate as a surrogate biomarker has worked in heart failure with reduced ejection fraction, but we don't know what it's going to do with preserved ejection fraction. LCZ696 has the target of natriuretic peptides. The surrogate biomarker is plasma NT-proBNP, and this as a biomarker, surrogate biomarker, hasn't worked in the natriuretic peptides in HFrEF. PDE5 inhibitors have the target of cyclic GMP, and it's possible that urine cyclic GMP may be a surrogate biomarker. However, this hasn't been formally tested, and it's the same for guanylate cyclase stimulators. So another challenge is selecting the appropriate endpoints. We know that mortality is lower, as we've had discussed today, in preserved ejection fraction than reduced ejection fraction in community cohorts. And this has also been the case in the large trials. So the DIG preserved had a lower overall mortality, CHARM preserved as well, and lower heart failure hospitalisations. A greater proportion of HFpEF deaths are non-cardiovascular in the community. So we can see in HFpEF overall the cardiovascular deaths are higher, but the proportion of non-cardiovascular deaths in preserved ejection fraction is higher than in reduced ejection fraction. And drugs may have a limited effect on reducing non-cardiovascular deaths, which makes perfect sense. So which endpoints might be more appropriate to use in clinical trials? Firstly, there's symptoms and quality of life. So these are quite important to patients, but they're not linked to outcomes. There's the 6-minute walk test, which is both functional, it's a functional test, but it's also meaningful to the patient. But comorbidity may interfere with this test, for example, osteoarthritis. Peak VO2 is a functional test. It's meaningful to the patient, but it's difficult to reproduce in multi-centre studies. And looking at echo parameters, they're potentially reproducible, but they're not necessarily linked to outcomes, and they're meaningless for the patient. And the other big issue is selecting appropriate clinical sites. Clinical sites need to focus on both quantity, so that's patient enrolment, and also quality, so protocol execution. A number of the trials have had prolonged recruitment periods, and that is thought to be related to difficulty in confirming the diagnosis of HFpEF and also the need for cardiac imaging expertise. And as examples of this, PEP, CHF and iPreserve both had high dropout rates of greater than 30%, and they also had a problem with open label use of ACE inhibitor, which may have weakened the outcomes. And again, TopCat, which has been talked about today, the differences in the results between the Americas and the Russian and Georgian results is very apparent, and led to McMurray and O'Connor in an editorial that accompanied the TopCat trial, saying that possible factors such as geographic variation include differences in the clinical characteristics of the patient population in each region, as well as differences in standards of care and methodological expertise in the conduct of clinical trials. So, in summary, a greater understanding of the pathophysiology will help to delineate phenotypes and lead to more targeted clinical trials. Accurate and timely diagnosis of HFpEF remains a challenge, and better targeting of pharmacological interventions is needed, and clinical trials must incorporate these issues and others in their trial design. Thank you.
Thank you very much, Dr. Hopper. It's a very comprehensive view for the talks. I think we might have time for 1 or 2 short questions, and also we can bring also issues that related even for previous talks, because I think they're all intercalated and related issues. I think you have summed up this very well. Yes, there's a question at the back, and then in the front.
Thank you very much for the presentation. I was just wondering, do we know any definitive absolute biomarker for the HFpEF?
I actually would think that CMU probably better talk about that.
So you mean, the question is what I can't hear, is it biomarkers?
It's about biomarker. What are the best biomarkers? My understanding is this is NT-proBNP above 250. indicates that there's heart failure. But in terms of correlating it back to, echo parameters, you're probably better to speak to that.
Yes, there's some correlation, and also there has been advocated the use of biomarker in the process of diagnosing this condition. I mean, in the setting of heart failure, elevated biomarkers will be more confirmatory of the conditions. I think that actually has bring a very important message in the top case study as well. Because you can imagine a lot of these patients present with shortness of breath. They might be wrongly labeled as heart failure because they might have shortness of breath related to other causes. They might have ankle edema because they might have hypertension that might receive calcium channel blockers and many other reasons. So at the end of the day, I think biomarkers will be helpful to increase the diagnostic confidence of the condition. That's why actually we are encouraging more and more the use of the NT-proBNP and the BNP as well.
Thank you.
Yeah. Yes.
Can I ask a question from Professor Sanderson? You mentioned about left atrial failure, which is now regarded as in left atrial cardiomyopathy rather, or some people call as an stiff left atrial syndrome. So is it related to, because we talked about left atrial pressure, is it related to pressure or left atrial volume? How do we diagnose?
Well, I think you make some good points. I think you have to sort of think about an analogy like LVH and systemic hypertension. The atrium is dealing with a high pressure because it's primarily working at end diastole. And the pressure is already high, and it's having to shift a big volume. So there will be initially LA hypertrophy, and initially LA function will improve, will increase to compensate, but eventually then leads to exhaustion and failure. And all the usual things like increased fibrosis, and that's been documented, increased LA fibrosis. But I think there's been very little work on the left atrium, and also on the right atrium. The same thing is happening on the right side because we know that pulmonary hypertension is very common in these patients. So the right ventricle is also working, and right atrial pressure is also increased. So I think all those things lead eventually to atrial fibrillation, which is what often precipitates the admission to hospital. But we don't really have any, the simplest measurement is LA volume. And actually that correlates very well with outcome and symptoms, and that you can measure very easily on an echo. And I think if you want to, I've always felt that if you want a shorthand way of diagnosing HFpEF is if you've got a symptomatic patient breathless on exertion and you can prove it on a simple exercise test, just up and down stairs, they're breathless. If they've got LVH and they've got left atrial enlargement, they've probably got HFpEF. That's a simple clinical guide. It's not something for clinical trials. But actually, measuring left atrial volume may be one way of, when we're talking about trials, measuring left atrial, that's quite reproducible, and it could be quite a useful criteria for inclusion.
Yeah. I think I come back also with the increasing, suggestions, that in the future, because heart failure is such a complex situation in the HFpEF, therefore, there has been suggestions that we, in the future, when we enroll clinical studies, we might actually have to take more careful dissection of the different etiological factors and the phenotypes, that may be hypertensive heart disease, diabetic cardiomyopathies, or other causes. And therefore, when you consider certain clinical studies, because the mechanisms are different, therefore you might have to consider different hormonal blockers or other drugs with respect to different etiological factors. So that is something pretty intriguing ideas and might be relevant. For example, if you have diastolic heart failure related to hypertension, you might actually treat them differently from those patients with diabetic heart failure, for example. So that is another way. I would like to lastly ask John a question. How should we name the HFpEF? What's the best name in your opinion? There's no names that actually represent the current situation right now.
Yeah, I think that please, Sanderson, go ahead. No, go ahead. I know what you are going to say. Please go ahead.
I'm just thinking what to say. Because I think you're right, and I'm sure there is a good answer.
It's a dictionary.
I think we should drop ejection fraction. Okay, I think ejection fraction is actually a useless measurement. It's a measurement, it's a kind of surrogate for volume. You can, for instance, you can have reduced systolic function, and if you have a small heart, the ejection fraction actually goes up.
Yes.
So it's completely misleading. If you have a small heart, if you have LVH, I mean, if you have LVH and you reduce your end systolic volume, the ejection fraction will go up. So you can have reduced systolic function, but the ejection fraction will remain the same. It's just a mathematical thing, because ejection fraction is one volume over another. So if you have LVH and a smaller end systolic volume, your ejection fraction will go up. If you then put some systolic dysfunction in it, it has to go down a long way before it gets abnormal. So ejection fraction should be out. Okay, so where do we go there? I think the only way, really, I think there are different conditions, and I think people think, when I wrote my article, I thought they were all the same. They're not all the same. It depends on the etiology. So there are people with heart failure with small hearts and heart failure with big hearts. And I think the treatment's different. The heart failures with big hearts have got remodeling, and they will respond to the standard anti-remodeling therapy, which is beta blockers, particularly ACE inhibitors, okay, and aldosterone antagonists. The question is ones with small hearts. And to me, one thing which has not been done is we must try and prevent those people progressing. And that hasn't been really focused on in clinical trials. So I think actually we should just talk about heart failure. And we have patients with heart failure, with raised BNP, and then we say, is this hypertensive heart failure? Is this diabetic heart failure? Is this ischemic heart failure? Is this heart failure with a big heart or a small heart? And I think that's the way to go. But,
maybe also we have to, as Inge said in her last slide, that quality of life and symptoms. We are not treating echoes. We are not treating numbers. So at the end of the day, we want to treat patients.
Absolutely.
And we need the quality of life. Yeah. So for this, and then the other issues, they cut the shortcut for the ejection fraction, and then whether you need the BNP to improve your diagnosis, or how you look at the insensibility or the feeling abnormalities. That's controversial. We are, I think BMP want the last.
Yes.
Well, anyway, I like the idea very much of getting away from ejection fraction and having only heart failure with different, let's say, underlying etiologies. However, if you do that, you would not somewhere put a number or put something measurable to that diagnosis. I can tell you that our friends in Russia and other countries there, if they go and do a trial, will do exactly the same as they've done now here in the TopCat trial. They just want money. They just put the patient in, and they come up with the story that the patient has heart failure, whatever the etiology, and you get the same problem as TopCat has had. We've seen it before in other studies, where we did studies in Russia, huge numbers, and the cutoff point, they had a cutoff point fraction was 40%. All Russian 800 patients had exactly the same left ejection fraction, 40%. Which tells you something that how the studies in those countries are being done. So if you do not have anything measurable, you leave it to the investigator to come up with a heart failure patient. You will have all kinds of patients or all kinds of people, maybe not even patients, in a study who should not be in the study. Like
I think it's a very good point.